Dean Marlene Miranda is professor and Samuel A. Graham Dean in the School of Natural Resources and Environment, or SNRE, here at the University of Michigan. SNRE's mission is to contribute to the protection of the Earth's resources and the achievement of a sustainable society. Through research, teaching, and outreach, SNRE generates knowledge, trains practitioners, and develops tools to manage and conserve natural and environmental resources to meet the full range of human needs on a sustainable basis. In addition to her administrative leadership responsibilities, Dr. Miranda directs the Children's Environmental Health Initiative, or CEHI. CEHI is a research, education, and outreach program committed to fostering environments where all people can prosper. CEHI emphasizes the environmental health sciences and social justice components of risks borne by children in the United States and internationally. CEHI runs geospatial training programs at the University of Michigan and across the nation as well. It's leading a significant effort to develop geospatial informatics that support healthcare delivery and improvements in population health. If that wasn't enough, Dean Miranda also holds appointments in the departments of Pediatrics and the departments of Obstetrics and Gynecology at the University of Michigan. She herself is personally deeply committed to social and environmental justice. Today, she's going to speak to us about using geographic health information systems to develop diabetes management. Thank you very much, Dean Miranda.
So thank you very much for that kind introduction, and thanks to all of you for coming, and hello to all the people who are there on the webcast. I'm grateful for your presence, your e-presence as well. It's really a privilege to be invited to be part of this speaker series. So I do a lot of work on children's environmental health. The kind of technical bailiwick that we specialize in within CHI, and we always pronounce it CHI, and our standing joke is, if your name is C-high, then you're the opposite of high C. And if you're the opposite of high C, you could be good for children. Anyway, we've done all this spatially based analysis within CHI, and increasingly, as we presented the work in various places, people who were working on adult health endpoints asked us if we were interested in collaborating to take these same techniques or develop new techniques to address the questions they were interested in with respect to adult health endpoints, including diabetes. So oftentimes I talk about my children's environmental health work that my group does. But today I'm actually going to talk about diabetes management amongst adults. And if anybody has questions about children's environmental health, I'm happy to talk about that as well. So within CHI, we have a component center that's called the National Center for Geospatial Medicine. And the NCGM has a focus on something that we refer to as geospatial health informatics or geospatial health information systems. And there's a paper in Health Affairs that sort of defines these GHISs. So I think you've probably heard this term GIS a lot. Well, we talk about GHISs. And there's a nice paper in Health Affairs that sort of lays out what do we mean by all of that. But I'll tell you a little bit about it. So we use these geospatial health informatics to do this sort of to do data management, but a different kind of data management than you might be familiar with. So for every piece of data that we collect, we attach a spatial location to it. And we use that spatial location to attach each piece of data to other pieces of data via shared geography. And then we look at the underlying spatial structure and dependence in the data, and we try to exploit that underlying spatial structure and dependence to extract new analytical insights. So we do a lot of statistical analysis, and we do that statistical analysis in both aspatial models and spatial models. And what do I mean by that? Well, when I just described the way that you construct these data systems or these data sets where you're connecting things, you could connect all of them and say, oh, well, now I have this medical record data and I have a lot of life context data attached to these patients, but I'm not going to once I've attached that data, I'm not going to pay attention to where these patients live relative to each other. So I have a richer data set than I otherwise would have because of this geospatial health informatics, but I'm just going to do sort of standard aspatial approaches towards analyzing those data. Alternatively, you can look very specifically at the spatial structure in the data, in which case you would be doing spatial statistical analysis. And we spend a lot of time developing risk algorithms for the purposes of risk stratification or for market segmentation, because especially in managing chronic diseases, we know that there are individuals who take up an enormous amount of clinic time, an enormous amount of both public and private insurance expenditures, and figuring out ways to get to those people who are highest risk most effectively is a key part of what we're doing with this. And one of the objectives with all of this, of course, is to improve care delivery. So we define GHIS as a way to link health system and social and environmental data via shared geography. And this allows us to have a multi-dimensional understanding of both individual and community health status. So the great thing about GHIS is that it really helps us think about population health or community health, and you can define that community or that population by whatever geography you want. You can define it by county, you can define it by congressional district boundary, you can define it by school district boundary, you can define it by neighborhood boundary. You can use all that geographic information to help you look at this question in whatever way is most useful to your organization or to the constituencies that you're trying to work with. So what we're trying to do is elucidate what these relationships are amongst all of these different data so that we can understand patients not just by their medical record, but by the context in which they live. We want to be able to connect these data sets to all kinds of the kind of standard EHR data sets, to all kinds of external data sets, and look at these contextual influences on health. So I hope you recognize that this is a map of the state of Michigan. The great thing about being in Michigan is that we're the only state that has an anatomical prop for our geography, so surely you must recognize the mitten. And I'm gonna, excuse me, I'm gonna play a short little movie here. So this is a series of different data layers. The one on the top is actually an environmental data layer. The second one is the county, it's a political data layer. It's the political boundaries as well as it's got state transportation networks on it. And then there was a census data layer and then another kind of baseline layer of the overall state geography. And you notice that there were these green spines that were running through. I'll play it one more time while I'm talking. You notice that there are these green spines that are running through all the way through connecting these. So this is this idea of connecting different data layers to each other via shared geography. So looking at that spatial distribution, does anybody have any guess of what those green spines are marking? What do all those green spines represent? Did you see any spatial pattern there? You can see the little pattern of the green dots here. So it's like the terrible trick rhetorical question. That is the location of all of the McDonald's in the state of Michigan. Very important data to have accessible to you. But you can. So I did it for McDonald's, of course, but you can do it for whatever you like if you want it. We do a lot of work with people trying to figure out what's the drive time for the population to hospitals that can or health centers that can administer TPA. So what proportion of the population is within a 30-minute drive time of a TPA administering facility? So you can do it not just by how the crow flies, you can do it by actual drive time, those sorts of things. So you can connect all these different layers together however you like with whatever things you want to piece them together. We usually connect them together by where the patients live. So I'm going to tell you a little bit about a particular project that we're doing on diabetes. The goal of it's a triple aim project. It was one of the Healthcare Innovation Awards funded by CMMI. And the goal of it is it's the triple aim, right? So we have to improve healthcare, improve healthcare delivery, improve health outcomes, and reduce costs. And we're focused on individuals who are diagnosed or undiagnosed and living with type 2 diabetes. We are implementing this project in 4 different locations, all in the American Southeast, where the health disparities on chronic disease. Can somebody get me a glass of water? Or I can go back and get it. So we're focused on these 4 communities in the part of the U.S. where we have the most pronounced health disparities. And that includes 2 sites in North Carolina, in Durham County, North Carolina, and Cabarrus County, which is more in western North Carolina. Thank you so much. And then in Mingo County, West Virginia, which is in Appalachia, and then in the Delta region in Quitman County, Mississippi. So those 4 locations actually have very different demographics. So our thought is we're in a part of the country where health disparities are most pronounced, and we're in 4 different communities that are actually quite different from each other. So if we can get these health informatics systems working in these 4 different locations, that would be a nice thing. So the notion behind this is that we start off with this spatially enabled data architecture. It's not the greatest graphic, but it is a graphic of the overall project, so it's almost like a requirement of anybody working on the project talking about it to throw this graphic up. But we start with spatially enabled data architecture and analytics. We put all this data together, and that includes, these kind of who, what, and when questions. Who came to which clinic at what time, and where do they live, and all those sorts of things. And we do some analysis, and that analysis gets fed into activities that are going on in both the community and the clinic. And there's this partnership zone that we refer to where the community and the clinic comes together. So we might do some community-based clinical interventions. And then as you implement these different interventions, hopefully some things happen. Maybe things get better, maybe things get worse, maybe things stay the same, but we think you should be tracking all of that. So we have a series of metrics. So we collect all that data that then gets fed back up into the spatially referenced data architecture, and that might change the parameterization of your risk models or your market segmentation models, those sorts of things. So there's this sort of constant feedback loop and iterative continuous quality improvement. But to give you, so when we think about outcomes with patients, so you know that for diabetes, so I actually should go ahead and say this. I know that it is completely politically incorrect to refer to persons who are living with diabetes as diabetic. I guarantee you that I will stumble into being completely politically incorrect in this talk because I am in fact diabetic and have been for a long time. So this new how I'm supposed to refer to myself, I still haven't quite gotten on top of it, even though that's been around. So forgive me for my for not being sufficiently sensitive to myself. So just think about as part of the triple aim that improve health outcomes, right? So here's a histogram of glycosylated hemoglobins across one of our locations. So I'm going to show you all data from one location so you're not trying to compare apples to oranges since these sites are quite different, right? So this is from Durham County, North Carolina, and this is the glycosylated hemoglobin values. And in general, we think that if people have a glycosylated hemoglobin that's below 7 and they're diabetic, we think that they're in control, if you will. Between 7 and 9, we're quite, they're not in control, but it's above 9 when we see the very worst acute complications associated with diabetes. And there's a lot of arguments right now about whether glycosylated hemoglobin is what you should be looking at. Should you be looking instead at other markers of cardiovascular disease? The point that I'm trying to make with this diagram is whether you think this is a good marker or another, it's not unlike if I looked at some other markers, there's this distribution, right? So if I'm going to improve health outcomes and I'm going to spend money in improving health outcomes, then I need to look at this diagram and think a little bit about, well, what do I want to do exactly? Do I want to take this far right-hand tail, which is where the most serious complications occur, and try to scoop some people up and get them on the other side of 9? Is that my way of improving health outcomes? Am I trying to take the entire distribution and shift it to the left? Am I going to try to get the people who are between 7 and 9 and get them moved into below 7? Am I going to try to get the people who are above 9 but closer to 9? Who exactly am I targeting in all of this, and where am I most likely to gain some traction with individuals and actually, because each one of those things I just described could be characterized as improving health outcomes. So I'm a data and quant person. That kind of conversation needs to go on iteratively between me and the clinicians, or my group and the clinicians, to sort of be clear. And one of the things that I think our quantitative and analytics group does is it sort of puts a spotlight on these sorts of questions of, when you say you want to improve health outcomes, let's be clear about what that means, and let's think a little bit about what the costs and strategies might be associated with the different approaches. So to just give you a little exploratory data analysis, I like to show a lot of maps when I give talks. So this is again from one of the sites in Durham County. This is actually only the patients who are in the Duke Health System. We have all of the data from the federally qualified health center as well. We're working on integrating that data right now, and once we get those two data sets integrated, we actually, because Duke owns both of the hospitals, and the only other hospital in the county is the VA hospital, which has a very particular patient base associated with it, we actually end up getting coverage of about 95% of the people once we bring the FQHC data in, but that's not in here yet. So on the far left-hand side, what you can see is a choropleth map of the percent of patients with diabetes. And in each of these maps, there's a general theme of the darker the color, the worse the blank. So here, the darker, the more intense red that you see, the higher the percentage of patients with diabetes. And because of, you can see that there's some spatial clustering going on. I do want to point out, I don't have a pointer, so in that upper right-hand corner there, oh wait, I can do this, right? That's more effective. In this upper right-hand corner here, where you see quite a bit of this dark red, and you think, boy, that's a very high-risk place, that's actually a very sparsely populated part of the county. So a patient or two more with diabetes can swing that color. So that's one of the things you need to think about a lot within the context of doing these map-based applications. And people have this tendency to want to just eyeball maps and draw conclusions from them. We think you should actually do analysis rather than just eyeball things, and that's part of what we do. So the middle graphic is the percent of diabetes patients with no HbA1c recorded. So standard of care is for people, thank you. Standard of care is for people to get a glycosylated hemoglobin every 6 months. When I say here that no HbA1c is recorded, it means between this time period, for patients who have been diagnosed with diabetes, we have no recorded glycosylated hemoglobin on them. Even though the average number of times the patients who are in here are visiting the health system in one way or another, the average is 13. So it's not like, well, they were in the health system's database once and then they stopped coming to clinic, and we're touching them on average 13 times a year, but somehow or another we're not getting a glycosylated hemoglobin done. And you can do a glycosylated hemoglobin regardless of what, when was the last time people ate, or whether they have a fever, and it's just a pinprick, and you can get a result in 6 minutes in clinic right now. So the one on the right-hand side is of the people so it's about 25% who don't have a glycosylated hemoglobin done. The one on the right-hand side is the percent of the diabetes patients who have a glycosylated hemoglobin recorded who are above 7% on their A1C. So you can see there's a little bit of a spatial concentration right here and in this area right here. So you start to see a little bit of pattern. So I'm just showing you a few maps to start thinking about things. So this is the mean A1C lab results and this isn't, I don't mean the mean at the individual level, I mean within these geographic areas, and these are census boundaries, what's the mean A1C for people who are living in these geographic areas. And here you see a very clear spatial pattern, right, with a concentration of higher A1C. So this darkest red color is the mean between 7.8 and 8.4. This is also the most densely populated part of the county as well. So you can see there's a real concentration of people who are out of control This is a time series of the same thing, the mean glycosylated hemoglobin, but it goes 07, 08, 09, 10, and 11, and they're all done on the same Choropleth scale. So if it turns darker, it's getting worse. If it turns lighter, it's getting better. And you can see there are certainly some areas of the county, in particular these areas towards the northern part of the county, which is predominantly white rural population. It does get better, and in some areas of the county, it sort of it gets a little bit better, it gets a little bit better, and then it kind of goes back again. And this is, again, sort of a low-income, higher percent minority communities within the county. So you could actually, if you think about it, with results like this, you could see a mean improvement in the county, but that mean improvement in the county could be constituted by mean decrements in certain parts of the county and mean increments in other parts of the county, right? And this is where the geospatial systems really come in handy, because ideally what you want is improvements across the board. If you do get improvements, you want to understand where those improvements are coming from, literally where they're coming from, right? So this is another map that shows, this is the percent of Duke patients who've had 5 or more ED visits in a single year. That's I think that's a lot of ED visits. I do believe that, so one of my I have 3 children, and one of my standard theories about parenting is if you've never been to the emergency department with your child, it means that you are too protective of a parent. And I would just like to say that I have established myself as not too protective of a parent. That notwithstanding, I do not, 5 ED visits a year is a consequential number of ED visits. But this is for all patients. This is for the patients with diabetes. So, and it's on the same Choropleth scale, right? So the darkest blue represents the same numbers as 10 and a quarter to 32.4 is the percent range there. So these are quintiles, okay? So you can, it starts off quintiles here, and then we see what happens here. So you can see the whole map gets darker, right? You can actually eyeball that. But the whole map essentially gets darker with a few exceptions. And there are places where there's this very heavy concentration of this sort of active ED use. So what we set out to do is, having sort of explored the data that way and come to understand a few things that were going on in the county, we set out to screen electronic health record data to identify patients who are at greatest risk of serious outcomes, and use that risk algorithm to target interventions efficiently. And our hope is that if we do this well, we can replicate it in other locations, and we can also, I actually hope that we can replicate it on other health endpoints. And the nice thing is we actually have 3 replication opportunities within the project itself, right? So you can develop things for Durham County and see how well, if you start developing it in Durham County, how well does that replicate to the other 3 locations. You can start in a different location and see how well it replicates. So you can look at this sort of stability of the results that you get across different types of communities. The basic idea here is that we take a combination of medical risk and social risk data, or these, where we're trying to come up with these medical and social risk phenotypes, if you will, and we analyze all that data to put people out in this risk algorithm to say, these people can go into a lower intensity intervention, these people can go into a higher intensity intervention. So why is it important to look at medical risk and social risk? Well, medical risk, which you get from the EHR, tells you a little bit maybe about the fragility of somebody's diabetes case. But the thing about social risk is about 90% of diabetes care is self-management, right? So I'll use myself as an example here. If you looked at my medical record and you saw, well, how long have I been diabetic and those sorts of things, you would say, well, there's a little bit, there's some brittleness in this person's diabetes, and there's some medical risk here. But if you then look at my social risk and you say, well, she's married, she's got good health insurance, she's got a stable job, she's got a good social support system, she sees her doctor regularly, she's got, reasonably good educational attainment, she understands her disease, understands nutrition reasonably well. I don't really have much in the way of social risk. So even though my medical risk is a little bit brittle, I'm pretty good at that 90% of my care that's self-management, right? So you could imagine other people who have less brittleness in their medical profile, but who are just socially overwhelmed or socially highly unsupported. And you can imagine that even though they have less brittle medical risk, you would actually want to devote some resources to them because of that sort of social risk that they have. So this gets people out on these intervention spectrums, and what the different colors of these diamonds are meant to represent is different geographies. So in this sort of putative example here, what we have are 4 people from a particular neighborhood, the blue neighborhood, who require higher intensity intervention. So in addition to those types of maps that I showed you up above, I can also map where are all the community resources, where are the community centers, where are the schools, where are the churches, which churches have health ministries, where are the soccer fields, if I, where are the tiendas if I'm trying to get to the Hispanic population, all these sorts of things, right? So not only can I look at how is this risk, what does this risk look like in different places, I can compare that to venues that I might have for reaching out to people and connecting with them. So the approach that we take in developing the risk algorithm is we take 1 year of data and we use we take 1 year, I'm pressing on the laser pointer to try to advance my computer and that is not working. So has anybody ever done this? Do you ever walk in from your car and as you walk to your office door, you press the unlock button on your car keys and amazingly your office door does not open? So am I the only one who's ever done that? Every time, it's not like I do it a lot, but I've done it like 3 different times and each of the 3 times I've done it, I've just laughed hysterically at myself and that of course attracts yet more attention to your I'm an academic. I get to have my eccentricities, I guess. So we used data from 2010 to predict outcomes in 2011, right? So we have 2007 through 11 data, and we define serious outcome. For the risk algorithm that I'm going to show you, we defined it in this particular way, where we said, if somebody has an inpatient admission with a diagnosis, where the diagnosis is related to diabetes. So if you were in a car accident, you were a passenger in a car accident and you got a compound fracture, you had an inpatient admission, but it probably didn't have anything to do with your diabetes, right? So we have this series of conditions that we say, well, these types of conditions might be related to people's diabetes. So if they get admitted to the hospital with a diagnosis of one of these conditions, then we'll say they've had a serious outcome. Or if they die, that seems like kind of a serious outcome as well. So we use the data from 2010 to predict whether or not somebody has a serious outcome in 2011. And then, then we've parameterized this model, right? And then we validate that by looking at how well does what we've predicted on 2010 data, this parameterization that we've developed using 2010 to predict 2011, if I use that parameterization and make some estimates of who's going to have a problem in 2012 based on what we're seeing in 2011, how good of a job do I do predicting that, right? So that's my out of sample validation, and you can do a true out of sample validation by finding people who weren't in the 2010 data at all or the 2011 data that you used for this combined analysis, right? Because I'm not explaining that well. In this initial step, you have to have people who are in the data set in both 2010 and 2011. In the validation between 2011 and 2012, you can do it on everybody who's in the data set between 2011 and 2012, or you can do it based on people who are in 2011 and 2012, but were not in 2010. So that's a true out-of-sample validation, right? So you can do it in a variety of different ways. And you can also look at how well does that prediction work across different geographies, right? So when I say data, we use a variety of different data, including clinical data, laboratory values from the EHR, demographic data to represent what the communities are like where people are living, as well as utilization data. And we're constantly accruing more and more data that's relevant to this project. So just to give you a sense of, so here's the risk algorithm divided from lowest risk to highest risk, and this is what we call a divergent polychromatic point choropleth. I know you're writing that down thinking, I want to be able to get up and give a talk and say divergent polychromatic point choropleth. I know, it's an exciting by Lynn. So the idea here, divergent polychromatic, means that I'm going from cool tones to warm tones, right? So the cool tones is lower risk, the warm tones are higher risk, and it's a point map. So these are all the people, all the diabetics in the county, and this is what their risk estimate is. So, and here's where their location is. I will tell you, this isn't actually where their location is, because it would be a violation of my IRB protocol, even at this scale, for me to put people exactly where they live in the county. So I use this process of jittering before I come and talk with you about it. But the way that we jitter the data preserves the underlying spatial structure and spatial dependence. So in this map and in the next map that you're going to see, if you feel like your eye is telling you something, even though I've jittered the data, your eye is actually legitimately telling you something. So it's a little bit hard to see from a distance. So I cut out that middle part where you see that right here, where you see this 27701, and blew it up a little bit so you can see. And it's a little hard at this, with these point maps to see what the pattern is, right? So instead, what we did is we said, well, what if we map this as a density map? So there's a series of different tools. So that was a point map. A density map says, show me the density of the risk. And when I show this to you, you probably see a spatial pattern pretty easily. So the darker the color, the more I go into true true dark patches, the higher the risk. And you can see that there's a very clear spatial pattern here, with a concentration in these neighborhoods here and in these neighborhoods here. So we use all of this to both determine what's the intensity of intervention that we offer to people, as well as where are we going to offer those interventions. And then we track how well those interventions work. So there's this intervention flowchart, and I'll be very clear about the fact that my group represents the backroom technical analysts on this. We are not the people who are out in the community doing clinical care. I have done a lot of community engaged work, and I can tell you a lot about what's gone well and what's not gone well in the community engaged component of this, but the real experts on the interventions are collaborators in other locations. So there's a high-risk intervention that includes home visits by a team and assistance that's provided between visits. And the teams have nurses and nutritionists and social workers and pharmacists and those sorts of things. And there are about the enrollment. This enrollment is actually a little bit closer to 250 now. I realize I didn't update that number last night. But the goal is to enroll 250 people in this highest risk intervention. Then we have a moderate risk intervention where we have calls made by an interventionist. We have mailers, and then these lowest, so there's 150 that we're trying to get in there, and there's a geographic we have a geographic pilot area. And the lowest risk intervention are actually things that we're rolling out across the entire county, and some policy changes that we're trying to get in place across the entire county. But again, I wanted to talk with you about geospatial health informatics, so I'm not going to go very deeply into what those interventions look like. So if you think about this risk algorithm that we described, I talked about predicting serious outcomes, right? But you could define serious outcomes in different ways, right? So we started by defining serious outcomes by hospitalization and death. we're doing a little bit of work looking at 30-day outcomes, both 30-day readmissions or 30-day mortality, which we all know that CMS cares about. So it'd be useful to see whether you, what's predicting that, who you should be reaching out to if you want to improve those metrics. You could look at things like adverse events, you could look at utilization, you could look at cost, you could look at quality of life measures if you have any patient-reported data. I think increasingly health systems are trying to get patient-reported data on quality of life. So the structure of how the risk algorithm works and the way that you do the analysis is flexible to the outcome that you care about, right? And it's flexible to the geography that you care about. And one of the things, of course, that would be really interesting about this, if you think about ranking people by their relative risk, right? And you use one serious outcome and you rank people, and then you say, okay, I did that ranking based on hospitalization and death. Now I'm going to do the ranking based on cost, or I'm going to do the ranking based on 30-day outcomes. You learn really different things if, when you do those rankings, everybody's in about the same place. That teaches you one thing. Alternatively, you could learn, when I do the ranking this way, this is how people line up, but when I do it this other way, here's the movement across that ranking, and when I do it this third way, it's yet different. So this whole idea of, can we get at sort of, so the triple aim is about accomplishing a lot of different things in this same, with the same kinds of interventions, with, it may be a comprehensive intervention, but this kind of approach allows you to think about all of those different aims and how they trade off against each other. So we look at as we're tracking the success of these programs, we look at a variety of different endpoints and metrics. I'm a really big fan of thinking about metrics with any intervention. It was very funny on this project when we first started. I suggested, just based on my knowledge of diabetes, which is actually something I know a fair amount about, my exploration of the data, I came up with what I thought would be 5, best metrics to use. And there was a lot of discussion amongst the many clinicians who were involved, and thus ensued a 6-month time period where this committee went off to sort of talk about, well, what are other metrics that we care about? And they came back with 57 metrics. And as I really wish I'd had the opportunity to weigh in on that, but when they came back with 57 metrics, and I said, okay, if you have 57 metrics, I can guarantee you that not all 57 are going to move in the same direction. I'm just going to guarantee that for you. Some of them will get better, some of them will get worse. So bottom line, what are the metrics that you care about the most? What are the ones that, if you get those moving in the right direction, you're going to be the most pleased with? And what they named off was the initial 5 metrics that I had recommended 6 months before. It was just the funniest thing I'd ever been involved in terms of an iterative research process. So the other thing that I want to emphasize about this geospatial health informatics is that we're not using cohorts, we're using populations, right? So you're looking at people who you might start with a cohort. You have an initial cohort. You might add some people who joined the study. You might add some more people. It's really funny when I got this graphic from the person who prepared it for me. She's a very optimistic person, so no one ever drops out of her studies. So you don't see any, but in fact, sometimes people drop out of their study. You have lost a follow-up. On a population basis, you have an initial population, you refresh the data, and when you refresh the data, you have new patients, you have people who have recently moved into the county or whatever the geography you're looking at. Then you have some people who've moved away from Durham. I'm telling you, she's very, very optimistic. Nobody ever dies in her graphics either. Come on, that's funny. And then you have a second refresh of the data. So you're thinking on a population basis on regularly, and you might narrow the data down a little bit if you require 3 years of longitudinal data, but it's just a different conception of how to follow people. So this is the article that I mentioned that was in Health Affairs. My colleagues Jeff Ferranti, Ben Strauss, Brian Nealon, and Rob Califf and I wrote this and published it, I think it was last year in Health Affairs. It's a nice explanation and gives some good examples from other substantive areas besides diabetes that you might find interesting. So I'll just end by acknowledging the Bristol-Myers Squibb Foundation, the Centers for Medicare and Medicaid Innovation, all of the staff in both healthcare settings and informatics. These really amazing communities that we work in that allow us to learn a lot from them. And of course, UMOR, who especially, it's really funny, especially when you become a dean, you become even more appreciative of the people who keep you and your faculty out of regulatory trouble. So with that, I'll stop and answer any questions you might have. Yep.
Dr. Miranda, are you in touch at all with the folks who are funded by the Robert Wood Johnson Foundation who look at super utilizers? Following Jeff Brenner's model of these folks who really there's other things going on, but they're super utilizers of emergency room care?
So for the people who are online, the question is, are we in touch and working with the people who've been funded by RWJ to look at super utilizers like Jeff Brenner and the Camden Coalition? So the funny thing about Jeff Brenner and I is that we are like the 1-2 punch on panels. I've been at numerous conferences where we give talks one right after each other. The first time I ever gave a talk right after him, he got up and talked about some market segmentation stuff and said, he works with these people. And so I'm a Bayesian spatial statistician. He gets up and he says, I work with these people, they have this prior information, they use it to develop these models, they get information out of it, they collect some more data, then they use the data that they collected from their interventions to feed it back in. And he says, the epidemiologist in me cringes all the time. These people are doing voodoo, and they are doing voodoo spatially, but it really works. And so then I get up and I have to say, you remember when Dr. Brenner talked about people who do voodoo? That's what I do, except we call it Bayesian spatial hierarchical modeling. Which, I don't know, is it more fun to say that you're a Bayesian spatial hierarchical modeler, or is it more fun to say that you're a practitioner of voodoo? So I'm well aware of the work that's going on there. The first grant I ever got to work on this type of health informatics came from Robert Wood Johnson in 2001 or 2002. So they made the initial investment in some of this work that we started doing a long time ago, working with pediatric practices to improve some of their screening strategies. So with the super utilizers, it's an interesting thing. It's one of the reasons why the contrast between Camden and these 4 sites in the South is really interesting, because in the South we never built giant towers to house our poor people, right? The public housing is structurally very different. So you get this hotspotters work that Atul Gawande wrote about. It's a little bit easier in a setting where you put all your poor people in a tower to identify a spatial hotspot. And what's interesting is the last time I talked to Jeff is they went ahead, they put a clinic right there in the towers. It's in the same tower. You just have to go down the elevator. The elevators are working and everything like that. And they're still having problems getting to those super utilizers, even though they couldn't have made it more convenient. So, it's really good work. I have a lot of respect for what Jeff and his group are doing. I do think it's important to think about the different contextual. That's the beauty of doing this geospatial stuff. You can look at the context, whatever that context might be. Yep.
Miranda, what do you see as some of the most promising directions, kind of building on this foundation that you've done? And I'm interested now that you're in Michigan, as you look around in Michigan, what do you see as some of really exciting applications or areas in this region?
So the question for those who are online was, what are some exciting new applications for this, and is there good potential for this work in Michigan? So in answer to the first question, I think that geospatial health informatics is incredibly useful for chronic disease. And increasingly, as we've moved towards a population where we're a little bit less concerned about communicable disease and much more concerned with chronic disease management, the model of, one endocrinologist seeing one diabetic in one exam room is probably not going to work. So if we don't find some community-based, more population-based approaches, the healthcare ship is going to sink. So I think understanding this combined medical and social risk in the management of chronic care and thinking about how that plays out across space and time is where there is incredible promise for this. And it's certainly where when we propose to do work around it. Also in children's health issues, so we're doing some work with the Kellogg Eye Center right now, looking at Medicare and Medicaid data for amblyopia and strabismus, and doing comparisons across different locations. So we've looked at the data in Michigan, which is primarily managed care, and looked at the data in North Carolina, which is primarily fee-for-service, and you're seeing kind of different patterns emerge. And of course, each of those places has some of the other, right? So you look at these compare and contrast. So there are a lot of pediatric issues that we, so looking at immunization, timeliness to immunization, overweight and obesity, kind of standard best practice screening. And in terms of what's the potential in Michigan, my intent when I came here, so I grew up in Detroit, and so the idea of coming to the University of Michigan, where I could come back to my home state and try to deploy some of these tools in service to the state, was very attractive. We're currently negotiating with the University of Michigan Health System to be able to get access to the data, as we have to about 4 or 5 other health systems right now. We have been doing pro bono work for vital records in MDCH, and so we've been doing this pro bono work for them with a bunch of data that they needed cleaned up, and so in return it would appear that we're going to get access to some of the we're going to get access to the vital records and some of the other screening data as well. And we have an ongoing conversation with the whole group of people in Genesee County to look at, that includes the Federally Qualified Health Center, the local health department, Genesis Health, Priority Children, U of M Flint, U of M Ann Arbor, trying to develop a GHIS for Genesee County. I'd love to do it in Wayne County. Wayne County is a little bit more complicated because of the scope, the scale, the politics, and the number of different institutions you need to get sharing data in that setting. So, yep, Jenna?
I'm curious how well the risk models you learned transfer across different geographic locations and populations.
So, so far, they seem to be translating pretty well. What needs more tailoring, I would say, is that, so our site in Appalachia, it's a predominantly low-income white population. Our site in Mississippi, that's in West Virginia, our site in Mississippi is a predominantly low-income black population. Our site in Durham County, North Carolina, has a substantial minority middle class, and is about 48% minority. So there's high minorities in the county, but a substantial middle class. And the county out west in North Carolina has a substantial lower middle income white group. So they're really different populations. The risk model seems to translate pretty well. The cultural tailoring of the interventions, I mean, what works in the Delta in Mississippi is not necessarily what works in Cabarrus County, North Carolina, right? So that kind of cultural tailoring becomes really important. Yep.
Miranda, sorry to interrupt. We'll use the microphone so you don't have to repeat the question.
Oh.
Is that okay?
Yes.
So I found the model of the medical and social risks integrated really interesting and compelling. where does the information come from for the social risk, right? You talked about the medical data coming from EHR, but how do you collect and aggregate the social data? What are the ways in which you do that?
Okay, so there's a couple of different things that we do. You can certainly, so I would say, for example, one indicator of social risk has to do with some basic information that you actually have in the electronic health record, like does this person have insurance? Another thing with the health systems that we've worked with, typically what health systems do is when somebody reports a new address, they overwrite the old address so you don't have any history of what people's addresses are. With the health systems we're working with, we've gotten them to archive the old addresses so you can look at residential stability, which is another nice indicator of social risk. And for the children's work that we do, that residential stability, man, is that important. We have kids that we've worked with who've, are in, grades 6, 7, and they've never managed to finish out a school year in the same school. They've, always moved and oftentimes moved a few times. So there are some things in the electronic health record. But then what you do is you decide whether or not you want to do any of these patient-reported outcomes when patients come in, and that's easy to build into your electronic, it's easy conceptually to build it into your electronic health record. So you can do that. But the other thing that we do in the absence of those other data is we use geographic location and a variety of different ways of characterizing the social environment. So for example, we have a whole series of methods that we've developed for characterizing the quality of the built environment, like how nice is the neighborhood where this person lives, and you can define the neighborhood at whatever scale you want to, and these measures still work. We have found that we developed a local spatial measure of racial residential segregation, which actually correlates pretty well with people's reports of their sense of social stress. There are also these neighborhood development indices that have been developed that are composites of census data. And then, Dolores Acevedo Garcia, funded by maybe RWJ, just came out in Health Affairs with this really nice, for our children's work, this really nice child opportunity index. You can also look at things like what are the amenities and disamenities, so you can map all of the crime data and get a sense of what's the nature of the public safety. You can map people's perceptions of things. So you can look at markers of territoriality, like grates on the windows, keep out, no trespassing signs, those types of things. So we use crime data, we use those sorts of things. We use building code, housing code violations, so that's publicly available data. So you just start getting really creative, and it kind of depends on what the problem is that you're working on. When I'm working on childhood asthma, I really want I really want building code violations. If I'm working particularly on a project with the Hispanic population, I really want to know a lot about what the support services are in the community for the Hispanic population. And so I might look at, and I want to look at where they get their information. So we automatically, when we're looking at kind of health disparities on a race and ethnicity gradient, we'll say, okay, well, we've got a map. So if I'm looking at Hispanics, I got to know where all the Catholic churches are, and I have to know what services they provide. I've got to look at where all the tiendas are. I've got to look at where all the soccer fields are within the schools. I've got to look at whether they have English language, English as a second language, instruction going on, all those sorts of things. So, what people oftentimes say to me is, oh, we'd love to collaborate. Can you give me a list of all the data you have, and I'll tell you what I'd like to work with? And we always say that's the wrong way to work with us. The way to work with us is to tell us the question that you're interested in. And then we can sit around and brainstorm what's the relevant data. We'll have some of it. Some of it won't be available, and we'll work with you to figure out what would be a good proxy for that. And some of it we don't have, but the question seems so interesting. We're like, okay, we'll go after that data. So for example, this project on amblyopia and strabismus, we've built a whole bunch of data layers specifically associated with that project because to get at those questions, we needed different data than we have. Well, it looks like there aren't any more questions, and in the absence of any more questions, I'll just thank all of you for your graciousness in inviting me here. I also like to end all of my talks by acknowledging usually I have a slide, but we have a center application that has to be uploaded tomorrow, so the fact that that's on applying big data to children's environmental health issues, so the fact that I've managed to talk about adult diabetes without all that parallel processing that's going on in my head slipping in. So I almost always have a slide that has photographs of my 3 children, my husband, and our dog. And because I always like to make the point that my family helps me to be a better scientist every day. So thank you very much for coming. And I hope that any of you who are interested in these sorts of approaches will come talk to me or grab a card or send me an email, and we'd be happy to talk with you about potentially working together. So thanks a lot.